Hello, everyone. Welcome to the latest edition of Raising the Bar Live. Today, I have with me Dr. Prisciliano Salas, the co-founder of Salvio Direct Care and the very newly minted Salvio Advisory. The doctors Salvio are early direct primary care practitioners in San Antonio and have a healthy and growing practice in the San Antonio and Hill Country areas. Every DPC practice is a little bit unique, and Salvio focuses not just on basic primary care, but lifestyle medicine as well. So how to be a better athlete, how to make your body perform better, all the things around that. So one, he's very interesting to talk to. But today we are going to talk about Salvio Advisory, which is I hate to say this, care coordination service. But basically what it does is help people with ongoing medical conditions interact with the medical system. And if you have an ongoing condition, I'm pretty sure you know how challenging that can be. But before we get to Salvio Advisory, I want to talk a little bit about direct primary care, what it is, what it isn't, and why it's so valuable both for an individual human and for an employer.
Absolutely, and I love that. And thank you for the introduction. Thank you for everything that you mentioned. And direct primary care, essentially what it is, it's the model of care, of how we deliver care. So people are so used to what most people know as fee-for-service or insurance-based care, where you provide your insurance to the office when you have a visit. You may have a copay, maybe not. Then on the back end, the medical clinic sends off the claim, and then that whole process goes to try to get paid. It can take anywhere from 30, 90, or even more days. And so the traditional system, the insurance-based system, kind of works like that, and it's very volume-based, right? I've had patients refer to it as sort of assembly line care. Direct primary care is totally opposite from that. It's direct primary care, meaning it's directly between the clinic or the doctor and the patient. And so with that, we eliminate insurance so that we don't have to deal with the hassles of having to bill the insurance and have to wait for payment and just be focused on volume, if you would. And instead, we can focus on actual quality medical care. Not that traditional, there are a lot of great doctors in the traditional system, don't get me wrong, but it's limited because of time more than anything. 7 to 10 minutes is the average visit you spend with a doctor in the traditional system. On the direct care side, you're spending 15, 30 minutes, an hour sometimes, right? And I'll be honest, sometimes I've spent even more than that, an hour and a half with the patient, because that's what they needed. And so we're not dictated by what the insurance says you can or can't do in the sense for primary care. And so it's strictly between doctor and patient.
So one of the things that I've seen over the last 15 years, and even more in the last 5 or 6 years, is that primary care doctors are very limited in the amount of time that they have. So typically they will address one concern, but they don't have time to address concerns 2, 3, and 4. So either a patient needs to be scheduled to come back, but I suspect what happens more often, and I say this because I look at claims data, is that a medication is prescribed to solve whatever the problem is, or a referral to a specialist is provided to get that person to a specialist. Now, I believe that a high quality primary care physician can probably manage about 80% of what a person needs. High blood pressure, high cholesterol, diabetes, how to steer off from diabetes, basic urgent care, cuts, rashes, UTIs, all that kind of stuff. So urgent care, all of that can be addressed in a primary care setting. So you're treating the whole person. I think you also want time for, you should maybe go to sleep before 3 o'clock in the morning and eat something green on occasion and walk around the block. Where that never happens in a primary care,
Right.
primary care arrangement. There's just no time. My assessment of treating 80% of what somebody needs accurate?
Yeah. Yeah. Honestly, I've heard anywhere from, different sources, 70%, 90%. We usually will say we can treat 99% of your primary care needs because we can, right? Everything that you mentioned on there. And you made a great point, and I want to mention on the list, if you would, of symptoms, or as we call it in medicine, chief complaint, right? What the patient is there for. Honestly, a lot of times numbers 3, 4, or 5 might be related. And so if you don't have time to listen to 3, 4, and 5, then you might actually miss something that you could have just very easily taken care of, with a little bit extra time. Instead, you're right. Sometimes you end up prescribing a medication to solve a side effect of another one because you're just trying to get through the visit. And more often than not, also, oh, well, I've done what I need to do. Let me just refer you to cardiology for your blood pressure. Let me refer you to orthopedics for your sprained ankle, right? Even though when they get to the orthopedist, they're going to do something that you could have very well done. Order an x-ray if they need to, put them in a brace, wait a few weeks, see if it's better. And if it's not, then, that's when you seek the specialist consultation. They're going to do the exact same thing, but now you generated another claim for the patient, time, lost revenue if they're having to take time off work, et cetera, and it just compounds from there when we could have just done it in the primary care office.
I see the rapid difference. We're noticing that in a good claim year, direct primary care patients cost about 25% of what direct primary care patients cost. And that will tick up to maybe 50% or 70% if there's a cancer claim or something like that. And that is what insurance is for.
Yeah, exactly.
Typically, we see huge cost savings, really typically about 90% in including the fee for the direct primary care physician. And I've seen it enough now that I know that that's normal.
Yeah.
I want to talk about lifestyle medicine because lifestyle medicine, I think, is a misnomer. To me, it's more of the advanced health analytics. Do you agree with that?
Yeah, actually, I think that's a good way of putting it.
Much more about what's going on with your body chemistry and how your body processes things, and performance enhancement.
Yeah, and lifestyle medicine. So lifestyle medicine is a relatively new board of medicine, but the idea of it has been around for decades. It's just, again, time to actually discuss with the patient, right? More often than not, your doctor might tell you, oh, well, you need to lose weight and eat better and, start exercising, and I'll see you back in 6 months. But as a patient, most of the time you're like, well, what does that mean? What does that actually mean? What do I actually do? What do I eat? How do I exercise? And so lifestyle medicine officially became a college or a board or a certification, if you would. I think now it's been, I want to say it might be under 10 years. But that's what myself and my wife, who are the two physicians in our practice, we actually subspecialized in that. And so the vast majority of our practice revolves around that. With every patient, we talk about the 6 pillars of health, because we know that these things in your lifestyle can directly impact your health right now. It can impact your health in the future, and more than likely impacted, what's been going on or what you've been dealing with. And so I'll just very briefly mention the pillars. We talk about nutrition. We talk about exercise. We talk about stress management. We talk about your sleep. We talk about avoidance or limiting toxic substances. And then this one is, I think became more apparent after the pandemic, this last pillar, but social connectedness. The importance that your surroundings and your social circle actually has on you and your health from a holistic standpoint. So it's a very holistic way, a whole person way of looking at the patient. And like I said, we do that day in and day out with every single one of our patients.
You also have a bilingual practice.
Mm-hmm.
How rapidly is your Spanish-speaking population going? And we're in San Antonio, for those of you that don't know. So we have a large Mexican national population here. How much of that is Mexican nationals, and how much of that is local people who have been here for, however long they've been here?
Yeah,
American.
most of our most of our population, I will say, is speaks English,
Mhm.
right? Whether it's because of the part of town that we're in the northern part of San Antonio, but our Spanish, or we'll say primary speaking Spanish speaking population has been growing. I think at this point it's still relatively low overall, but it is growing. I would venture out to say that maybe 10, 20% right now. And it's actively growing, month to month. So it's growing. I mean, that's all I can say.
I think it's important. We have a large Spanish-speaking population here,
Hmm.
so it's important to understand care in a language you're comfortable with.
Yeah. Yeah, understanding the language, or the medical language more than anything, but being able to translate that, right? Not just in layman's English, but then also, layman Spanish as well, which, can be very tricky if you're not super versed in that.
Yeah.
And that might segue into, the system and understanding the system and the coordination part of things as well.
Before we move on to that, I want to ask you one more question.
Sure.
So, you worked for a large practice, as did Mrs. Dr. Salas, and or a large on-site clinic provider. Why did you not continue on that path? Why did you decide to go out on your own?
Yeah, so I'll tell you from my standpoint. So actually, when I left residency, I started my own traditional, insurance-based practice. So it was just a fellow resident and myself. We very quickly, learned that, okay, you really have to hustle because we started with 0 patients. And we quickly, probably at the 4-year mark, had, I think, over 7,000 patients between the two of us. Okay. And those were registered patients. I think actually active patients, meaning that they at least came in, a couple times a year. I think it was closer to 5,000, but we had a total, portfolio, if you would, of 8,000. But I very quickly learned that, wow, this is a lot, right? I'm having to deal with at least 2,500, lives every year, seeing 20, 30 patients in a day. Technically, I should spend 7 minutes to 10 minutes of that with each visit, but I just could not do that. I just couldn't. I was always passionate about the lifestyle part, and I always tried to incorporate that. But of course, you can imagine what that caused. It caused me to get behind and behind and behind and behind. And so my patients were waiting and waiting and waiting. Now they knew that I was putting a lot of time into each of those visits. So, they didn't necessarily hate waiting, but nobody likes waiting a long time in the waiting room, right? So I quickly learned that, you know what, I can't work like this. It's not fair to the patients. It's not fair to me either. Even my health was starting to take a toll as well. I mean, I was working, 70 hours a week, charting all night on weekends. My wife was working full time as well. Obviously, we have kids, and so there's that into play. And so it just wasn't, for me at least, from my perspective, it was not sustainable, right? And that's a lot of even in medical conditions, you have to make sure that what you're doing or how you're treating things is sustainable. And so I decided, you know what, this is not for me. I'm not going to do this for the next 40 years. There's got to be another way. And that's when I discovered the direct primary care model. And I haven't looked back ever since.
One of the questions I get asked a lot is, isn't direct primary care how can you work without insurance? And I've known you for several years now, and you are looking calmer every time I see you. So I think that this system is working very well with you, and I hear that about all the things, direct contracting and cash pay, and all the things that you and I talk about. I think it's great for providers. They set their own fees, they get paid quickly and fairly. There's none of this clawback business. There's none of this, oh, you didn't dot the I the right way, so we're going to cut this out and make you do it 3 more times. I think it's actually very good for providers. I also very firmly believe that independent providers are better for patients. Do you agree with that?
Yeah, I think the vast majority of the time, yes, because again, you're not under the foot, if you would, of a big entity that's just looking at your revenue, essentially, right? And so you're no longer just worrying about a number, whether it's a number on a balance sheet or a number in a electronic medical record, right? When you're looking at patients, you're actually seeing a patient. And so by doing that, as you said, you set your fees, your patients know ahead of time what they're getting, they're not getting surprise bills. They know that and I didn't talk about this in the beginning, but for those that don't know, in a direct primary care model, it's essentially a membership type of medical model where you pay a flat monthly fee, but that essentially includes all your visits with your doctor, whether it's by phone, via text, in person. You're not paying copays. You're not having to worry about surprise bills or EOBs and invoices and codes and this and that. And it's just you're getting, you know what you're getting ahead of time. No surprises.
Now that we have entered the surprise bill and copay and insurance world, let's talk about Salvio Advisory, because I think this started out as a project to help some people and has expanded rapidly into a project helping a lot more people. Tell us what exactly Salvio Advisory is and who it is for.
Yeah, so Salvio Advisory in our case is a service line within our practice because we know the importance of care coordination. So Salvio Advisory is essentially that. We have a medical advisor that is the medical advisor for a patient. Let's say has a medical need, whether it's a chronic condition or an acute condition. And for example, they may want to see a second opinion with a different specialist. And so their doctor might say, well, you already saw, one specialist and that's what they said, and, that's it. But let's face it, some patients just want more information, want a second opinion. And so they can come to, if they're an existing patient for us, that's no problem. We know that second opinions are viable. We know that the patient should be educated and informed at the end of the day. And so we'll help coordinate that for them with a different specialist. If it's a patient that's not a member with us, they can become a client or a member, because we also actually sell that as a membership for just coordination. And then we'll help to gather all the information, all the medical records, which if you know or have ever tried to get medical records, even that alone can be so painful, right? And putting that together. So they'll meet with our medical advisor, they'll listen to their case, they'll gather all the medical records, they'll present that to the specialist, whether it's somebody that the patient wants to see or somebody that maybe we recommend for them. And then they'll help navigate that whole process and get them in on a timely manner rather than waiting, months, right, to see a specialist. We have a way to actually expedite that, right? Because we've built relationships with a lot of these specialists in town. I've been in practice here in San Antonio for over 10 years. Our medical advisor has been doing this sort of advising, care coordinating for, I believe, over 20 years. And so we've built a lot of relationships. But on top of that, we have a service where we can tap into and actually reach out to a nationwide of specialists. over 150 specialists across the country that there may be at big academic centers, or they are very well-respected private physicians in their communities, specialists of any kind, and we'll actually present the case to them and get a second opinion from them, which then we can relay back to the patient. And so what that does, it eliminates, if we go down that route, it actually eliminates time from the patient having to travel somewhere, having to schedule a visit, having to get, any kind of insurance authorizations or things like that. And they can have that second opinion at a much sometimes affordable rate, but also very quickly.
How important is very quickly? We were at an event last night, and there was a discussion about the prior authorization process and how you literally can kill people. Talk about how and why that problem exists and why it's so important to shortcut it.
Well, as you mentioned, unfortunately, sometimes it can lead to untimely issues, right? And the patient at the end of the day is the one that suffers, whether it's even from the medical equipment. I mean, there's times where even getting durable medical equipment or DME, delaying that process can actually be life-threatening to a patient.
We had a patient that died that way.
I'm sorry?
We had a patient that almost died that way.
Yeah, I mean, for crying out loud, right? I mean, that's ridiculous, especially in the US. But anyways, so you're essentially delaying care. So in our case, if there is something that is very urgent and we need to get that second opinion today versus tomorrow, the service that we use that has access to these nationwide specialists, we can get an answer from the specialist on average within 4 or 5 hours. Yes, you heard that right. 4 or 5 hours, not days, not weeks, not months. 4 to 5 hours. A lot of times, same day.
I think often waiting a day or so is fine. My concern is always waiting weeks or weeks, and my concern is for always, we had a client who had lung cancer and she needed a breathing apparatus, and the DME vendor wouldn't go through her insurance. They forced her to pay cash, and she didn't have cash. And we caught wind of that and solved that problem. But if we hadn't caught wind of that, she could very easily have died. And I think those are often the kinds of things that catch people, is they're not expecting to spend $3,000 or $4,000 for a piece of equipment that should have been covered by their insurance. They're not expecting to wait 2 and 3 and 6 and 8 months for a specialist. And they're not expecting to wait 4 and 6 and 8 weeks for a drug approval, which is for almost all PBMs just going to be rubber stamped at some point once everybody has been tortured enough. Talk about how you can shortcut So I think you started doing this, and then your patient said, "Could you do this for my mom? Could you do this for my sister? My neighbor's having this problem. Do you think that you can help them out?" How severe, how common is this problem, and how rapidly are people catching on that there is a way to short circuit it?
Yeah, it's a big problem. If we go back to what I mentioned earlier, your typical primary care office, per provider, whether it's a doctor or a mid-level, can handle on average 2,000 to 2,500 patients in their panel. So like we mentioned earlier, if you don't have the time to spend with these patients on the front end in the office visit, and you end up referring them out, think of how many referrals go through every single day, right? Yep. And especially if you're in a private practice, small practice, or even if you're in a big practice, you only have so many people that are keeping an eye on those referrals, that can actually follow up on those referrals. And I can't tell you enough how many times fax numbers are not what they really should be. Right, I can't tell you how many errors we get back from the system, like, hey, this fax number doesn't exist, or this fax number didn't get through. Or we follow up with the patient and say, hey, the next day, have this office called you about your referral? And more often than not, they say, no. We call the office and they say, oh, no, we never received anything. Or we also hear this one, oh, yeah, but, we get hundreds of referrals, so it's at the bottom of the queue, and, we'll get there when we get there, right? And so people are catching wind of this. Our own patients are, like you mentioned, their family members, even if they're not members, member patients with us. But I have a patient, for example, whose mother lived out of state, but there was a cancer diagnosis, and they went to the Mayo Clinic, and the Mayo Clinic said, hey, okay, well, this is the treatment that we're recommending for your cancer. The patient asked, well, I heard there's this test that you can do to see if the chemotherapy will actually work for my type of cancer. The specialist said, you know what? There is actually, but we can't order it. We're not allowed to order it. We, the Mayo Clinic, cannot order that test. I think it was more so because it wasn't going to be paid by the insurance, more than likely, because it's more research or experimental. But they said, if your primary care doctor can order it, we'll take a look at the result for sure. Their primary care doctor didn't want to do that, so they reached out to me. I said, oh, of course, here's the test code. They even gave me the test code from LabCorp for the test review. And I said, yep, that's about right. It was very simple. We have direct pricing with the lab. We got, a price for cash rate for that test, which the insurance would have probably gotten billed thousands of dollars. I think they ended up paying a couple hundred for that test. And it was done, literally one day to the next.
I want to circle back to something that you just touched on. Somebody was at the Mayo Clinic and read about a test that could be performed to see if their physical person, this mother's physical person, would respond to this particular chemo. So that's a thing now. It's not just cancer, it's a whole host of illnesses that there is precision genetic testing to see if a person will respond to this particular treatment. And I think that one thing that people don't realize is that when the FDA approves a drug, they expect it to be efficacious in about a third of the population. That means you have a 1 in 3 chance of being one of those people. Well, what happens if this chemotherapy was wrong for her?
Mm-hmm. What if it's in the other 2/3?
Mm-hmm.
I mean, just think about that. And that happens every single day. So those types of things, precision medicine, personalized medicine, preventive medicine, those are all the things that as, independent, private, direct practitioners, not only do we spend time with the patient, but we can also spend time on our end updating ourselves and researching these things and implementing them if appropriate, right, in our practices.
And that's living, correct? I mean, precision medicine changes every day.
Yeah, it's changing every day. Now that we've sequenced the genome, there's so much information that we can gather from pharmaceuticals and, based on your genetics to even metabolism, how maybe one patient responds better to a carbohydrate-rich diet versus a fat-rich diet, for example. I mean, and it extrapolates from there on and on and on. And so, the research is always ongoing, but now with AI even, I mean, that's a whole other topic too, but now with AI is being used even to overread or help analyze, radiology studies. Yep. To help come up with these types of advanced therapeutics or diagnostic techniques as well. And so it's changing every day. It's exciting. It can be scary, but when you look at it judiciously, conservatively, evaluate the data, educate yourself, educate the patient, at the end of the day, that's what it boils down to, education.
I think so. How are things like direct primary care and cash pay pricing and advocacy? Because yes, it's called Salvio Advisory, but it's advocacy on behalf of a person. Mm-hmm. It's let me get you through this faster. Let me find somebody for you. Let me find somebody to help you. let me help you parse through this data so that you can make a good decision about how you want your own person to be treated.
Mm-hmm.
I think it's valuable for the human, and we kind of all agree on that. How is it valuable for an employer?
Wow. That's even more valuable for starters, just the numbers alone, right? If we're dealing from one patient to another, it's a single patient, a single family, for example. When you're talking about employers who are basically hiring a few to hundreds to thousands of people, and then you just basically multiply that, right, by the X number, and then you attach financial numbers to that, the economics of that. I mean, it's huge. There are some studies out there and articles out there, and this is based on Medicare, Medicaid data. So for those of you that kind of know what that's like, take it for what it's worth, right? And some studies, some journal articles might say, yeah, there's some benefits, some might not. But across the board, from what I've seen is, and this again, taking Medicare, Medicaid data, I think it's conservative. But on average, there's a potential 20% savings on health costs. Medicare, Medicaid data, not talking about complicated things, but more average things that can account to $1,500 to maybe $4,500 in cost savings per person per year.
Easily.
This is on average, Medicare spend, right, per patient. So that doesn't account for, big cancer diagnoses, dialysis, things like that.
Everyday stuff.
But just everyday stuff. So if even you just take the median of that, right, about $2,500, $3,000, then you multiply that by your number of employees. Maybe not 100% of your employees are utilizing the cost, but even if 50% of your employees are utilizing medical care, I mean, do the math right there.
Yeah. So the Kaiser Family Foundation number, I think, is close to $15,000 per employee per year in medical cost. Mm-hmm. So if you can reduce 20% of that, you're looking at $3,000, and that's average across the board. In San Antonio, that impact, our costs are lower, but that impact is higher.
Right.
And I think that also accounts for fair pricing and getting treatment that people need, avoiding treatment that they don't need, and making sure that people have access to care. It's heartbreaking to me how many people don't have access to care. Mm-hmm. Because they're terrified, because for whatever reason.
Yeah, I mean, again, I can give you another example just this week alone. Medical condition that progressed. The patient lost his job, therefore lost his insurance, and now is trying to figure out, what do I do because my health condition is deteriorating. They're trying to apply for, Medicaid, Medicare, disability, but let's face it, that takes time. And this patient fell twice over the past couple of months, but hadn't told anybody, hadn't even told me, because he was afraid of the costs that they were going to incur without having insurance in this transitional period. And this is somebody that is basically just went on dialysis. So you can imagine how critical it is, how critical a fall can be, a fracture, internal bleeding, etc. And so I had a cold, hard conversation with this, family about the importance of not neglecting even what might seem little things, like just a fall, because it can be detrimental immediately. And so I said, no, don't worry about the cost. Your health comes first. If, come to me, obviously, please let me know. We'll figure out the best cost-effective way. But at the end of the day, if we have to go to the emergency room, if it's an emergency, then so be it, right? But they were scared because they did that and they were turned away. They were turned away from the ER, not illegally in the sense, right? They got seen, they got assessed, but then even though the patient really needed to be admitted, they did not. They denied the admission and they sent them home.
340B care.
Mm-hmm. So that's a problem, and my practice, again, I went from seeing thousands of patients to just a few hundred, but if that's happening in our direct practice, it's happening everywhere. It's
Everywhere.
happening everywhere, every single day. And your documentary, I think, touched on that a lot. The cost of healthcare, right? That's the premise of it, and how just ridiculous it can be, from whether it's a PBM side or the hospital side or whatever. Um, Price inflation, et cetera, but people are just scared. They're scared of the cost of healthcare.
I
And
have a
that's
client
shouldn't be that way.
that has a workforce that is remarkably low users of care. And because of that, in spite of that, every 10 to 15 months, they have a big shock claim. It is typically an older gentleman who doesn't go to the doctor because he's afraid of what it costs, of what's wrong with him. Then there's all of this medication, then there's hospitalizations, then there's loss of limbs, partial loss of limbs, and then there is loss of life. It's horrible.
It is.
It's absolutely horrible.
And that happens every day. I mean, in San Antonio, especially, unfortunately, we have high rates of diabetes and heart disease, and so delaying care because you're scared of whether it's you're afraid of what's there, but really, I think it's more being afraid of the cost at the end of the day, because nowadays, there are a lot of very good generic medications, practices like ours where flat monthly fee, organizations that are trying to provide even more affordable or sometimes free care in the sense. There are ways. It does not have to be expensive.
I think that's always surprising to people, as one of the subjects of the documentary, Deb Alt from AIM, which is a medical management firm, her saying is that the right care at the right time with the right diagnosis is almost always the right price.
Mm-hmm.
Because healthcare itself is not, it's not cheap. Nobody can call it cheap, but it's not expensive when you have cut out many of the layers. And I think it's very confusing to people. And I think from an advisory perspective, you can unravel both sides of that, not just the cost perspective, because I think you are unraveling that, but the access perspective. And I think the access perspective is almost more important, because if you can catch things earlier, you can coordinate somebody's care, you can eliminate a lot of the excess. And there's a lot of excess in the healthcare system.
So much excess. And it just feeds into the way the system basically was developed into being reactive, right? Being reactive. And so we're not going to do anything until something happens. But in the meantime, we'll still take your premiums every day, and we'll just increase the price every day. And every year, et cetera, et cetera. But when you can focus and really target, like you mentioned, the right diagnoses at the right time, which that basically translates to a lot of times prevention, right? Preventing the complication, preventing the amputation, preventing the dialysis. Dialysis is the highest, I think probably next to cancer, but the highest expense to the healthcare system, because obviously with dialysis, the patient has to do it 3 times a week. And their life depends on that dialysis machine.
Yep.
So if we can prevent that way before that, then we don't have to be just reactive. We can be preventive.
That's kidney disease, a chronic condition. It evolves over time. So access to medical care prevents quite a lot of that.
Yeah, a lot of that. I mean, diabetes has so many even if we just focus on diabetes alone, which kidney disease is a comorbidity from that, right? But a lot of these conditions have then additional comorbidities or additional complications or sequela from these conditions that if you can target them ahead of time and be preventive about it, be actively preventive about it, then you, even if it progresses, maybe it progresses at a much slower rate.
And I think that is a huge cost savings. It's hard to prove, right? But it's a
It
huge
is, it's so
cost savings
difficult.
to employers. You
Mhm.
know, I say, and a person with diabetes and it's under control and they're getting their teeth cleaned and they're getting their eyes checked. Okay, it's not very expensive. It's an ongoing condition. It's not very expensive. It's the
Mhm.
person with diabetes that doesn't know and has a foot ulcer and ends up in the emergency room and just spent $40,000 of your money. That's a problem.
Mhm.
And that happens.
Exactly. Yeah, I mean, even if you paid for the dentist visit twice a year and the ophthalmology visit once a year, doctor visit 2 or 3 times a year,
Nothing.
yeah, it's nothing compared to the complications of being uncontrolled.
The other thing that I think we're overlooking is no employer with 100 or 200 or 500 or 1,000 employees can send all of their employees to one doctor.
Mhm.
It's not feasible for the doctor and it's not feasible for the employer. But
Mhm.
when an employer can offer something like this, then they are taking a high deductible plan and they're turning it into something that is actually valuable to people.
Mhm.
And I think that there's a lot of enhancement of the employer employee relationship when that happens. And we've been very lucky. Our clients always tell us, look, we spend a lot of money and a lot of time. Everybody hates it. Yeah, we'd like to spend less money, but could we just have people like it? Spend the money. And I think when you have options like direct primary care and advocacy, then
Mhm.
people like it. They
Yes.
understand that somebody is looking out for them, and good Lord, people need to be looked out for in the medical system.
Oh, for sure. I mean, even within the medical system, things can get, complicated and muddy. So, obviously, imagine on the other side, from the patient side, it's even worse, right? Even for you or me that know what the system is like, even then, there are still things that are like, really? How did that happen? Or I don't understand this.
Uh-huh.
So, if we can at least uncover most of those things, expedite the process, seek timely care, navigate the system. Like, hey, I know this is, for example, with imaging. I think this example is a very easy one. An MRI that with your insurance costs $3,000.
You order it, it's
Well,
400,
what was that?
and you order it, and it's 400.
Yeah, and we order it and it's $400 to $500. The exact same test. Same thing with labs, right? I mean, we get labs for like $3 a test.
Because that's what they should cost.
Exactly. And even at that $3, I guarantee you the lab is still making money.
Mhm. Very true.
So,
Before we wrap up, what would be your best piece of advice for employers looking to both do better by their employees, because many employers understand what they're doing is not containable or sustainable, and um, best for the employee and best for the budget?
yeah, I think from a business owner standpoint, healthcare, again, because it can be so complicated and difficult to understand and this and that, and like your documentary mentioned, people have almost just become accustomed to raises in the cost of their premiums every year. I think that what you really should be looking at or asking yourself is why, right? Why are they really going up? And look at your data. Look at your data. Talk to your benefits person, to your insurance broker, whoever it is that's helping you, or your HR, your benefits team, whoever it is that's helping you with your benefits, and look at your data. I know it's one more set of data to look at, but it really is going to make a difference, because if you don't understand it from the beginning, if you don't understand the healthcare system from the beginning, but then you don't even understand what's going on from a claim standpoint, then how can you really make an informed decision that's going to be best for your bottom line, but at the end of the day, best for your employees? Because who's sustaining your company at the end of the day? Your
Employee.
employees. Whether you're selling a service, you're selling a product, whatever it is that your business does, you rely on those people. So if you can understand what it is that you're actually offering them, I think it's at the end of the day, it ends up helping your bottom line. But you have to be willing to ask the questions, to understand and review the data, and make the change if you need to. Don't be afraid to make the change. Insurance, traditional, the big four, that's not the only way to offer health benefits. There are other ways. The direct model is one way, and there are other very creative ways that people like Allison and others out there can help you with. And at the end of the day, helps your employees and their families.
I think the biggest secret of all that we know is or the dirtiest secret is that high quality care is almost always in the bottom quartile of cost.
Mm-hmm. Exactly. And a lot of times they might think that it's an added expense, but unfortunately it's because, again, they're not understanding where they're spending their money, right? It's a matter of understanding really where those costs are going to, where their expenses are going to. If once you understand that, then it's almost like a veil has been lifted off of your face.
And it opens so many more opportunities for you.
So. Exactly. And at the end of the day, your company is probably going to be better from it.
Yep. And not just from an economic perspective, but from a workforce development perspective as well. So
yeah. Employee retention, satisfaction. I mean, we can go on and on.
I think we will leave it there. Thank you very much for joining me today, and we will see you next time. Click a like, helps us spread the word, and we'll see you again soon.